All right, so we'll go ahead and get started with the New Year's and the AMSSM Ultrasound Case Series presentations. So just a quick plug before we get started. Just wanted to remind everyone about the AMSSM Library of Sports Ultrasound Pathology. This is a great opportunity to take the pathology you see in clinic or in the training room or the sign lines and actually turn this into a publication. And so just a reminder that the AMSSM Sports Ultrasound Committee is looking for both common and unusual pathology related to sports ultrasound. And this is a great way for residents, fellows, and staff to add to the growing series of the Library of Sports Ultrasound Pathology and also get a peer-reviewed reference for your CV. So more information for this can be found at the AMSSM webpage under the Sports Ultrasound tab. So just a quick plug for this. And I know that this is something that I've personally done and found extremely worthwhile. Otherwise, now going to go ahead and introduce our speaker for today, which is Dr. Thea Swenson. She's currently a sports medicine fellow at the Vanderbilt University here in Nashville, Tennessee. She received her medical degree from the University of Colorado and completed a residency in PM&R here at Vanderbilt University. Additionally, she has a bachelor's of science degree in product design from Stanford University. And today she's going to be presenting on the pediatric anterior knee and Sinding-Larsen-Johansson syndrome. All right, Thea, so I'll go ahead and let you start sharing your screen.
All right, does that look okay? Can everyone
Yep,
hear
that
me?
looks great.
All right. Thank you, Dr. Schaff. So I will be, as Dr. Schaff said, presenting a case of Sinding-Larsen-Johansson syndrome or anterior knee pain in the pediatric population. I have no financial disclosures or other conflicts of interest to report. And here is an outline of my talk. So the emphasis of this talk will really be on scan considerations and protocol for ultrasound examination of the anterior knee with a specific focus in the pediatric population. The main point of interest being that I know, at least in my experiences, that I see a lot of adult patients in the clinics that I've worked in, but this will be a comprehensive ultrasound exam for pediatric knee conditions with a focus on the pediatric population. So we will start with our case, which is that of an 11-year-old male tennis player who presented with acute bilateral knee pain. The pain was worse on the left than on the right, and the symptoms were limiting his ability to play tennis, especially in tournaments. The knee pain began gradually over the last month, and it seemed to be related to tennis activity. There was no inciting trauma. He had no prior injuries or other knee conditions. And he described the pain as being localized to the anterior knee, especially along the proximal patellar tendon region. The pain was worse with bending his knee and performing activities like squatting and lunging. And there was no knee swelling, and he had no mechanical symptoms like the locking, buckling, weakness, and he had no numbness. And he had tried conservative treatment like rest, ice, compression, elevation with some improvement, but the knee pain was still limiting his ability to play tennis. On exam, most noticeable was that he had tenderness along the proximal patellar region, left greater than right, and his pain was reproduced with bilateral leg squat. Otherwise, inspection demonstrated normal alignment. There was no effusion. His gait was non-antalgic. He had normal range of motion with knee flexion to 130 degrees and extension to 0 degrees. And strength was 5 out of 5 with knee flexion and extension, and sensation was intact to light touch. We obtained bilateral knee x-rays, which were normal. There was no fracture or malalignment. The joint spaces were maintained, and there was no evidence of knee effusion. The soft tissues were unremarkable. So these images are just of his left knee, but you can see that his growth plates here are still open, and they haven't fused, so he's skeletally immature. This is the differential diagnosis we're thinking of for pediatric patellar knee pain. We, of course, have Sinding-Larsen-Johansson syndrome or jumper's knee, which is an overuse injury leading to an osteochondral defect at this proximal patellar tendon attachment and irritation of the patellar growth plate there. We have patellar sleeve fractures, which are rare injuries in which there is actually an osteochondral avulsion injury. These are more commonly acute and result from forceful contraction of the quadriceps muscle. We have patellar tendon tear or rupture, irritation of the infrapatellar fat pad or Hoffa's fat pad impingement syndrome, irritation of the infrapatellar bursa or infrapatellar bursitis, and then Osgood-Schlatter, which is an osteochondral defect or a traction apophysitis at the tibial tubercle, where the patellar tendon attaches here distally. So in this scenario, we really want to ask ourselves if ultrasound will be useful, if taking that time out of clinic would be helpful. And yes, we think it would. So ultrasound is readily available in our clinics and gives high resolution imaging of the patellar tendon without actually having to send the patient out for MRI. It allows for vascular and dynamic evaluation, which can be useful if the differential includes apophysitis and tendon tear. And for these exams, we use a high-frequency linear transducer and position the patient in supine with knee in slight flexion, about 15 degrees, using either a towel or other prop under the knee. So this is the AMSSM guideline protocol for what we should include in a routine anterior knee exam. You have the quadriceps tendon, the suprapatellar recess of the knee joint, the patella, the prepatellar bursa, the patellar tendon, Hoffa's fat pad, and then two infrapatellar bursas, the superficial and deep infrapatellar bursa. These are the optional structures for more advanced scans, but wasn't included in the scan that we did because our focus was really on the abnormalities in the patellar tendon. Regardless, here they are. They're the vastus medialis and medial retinaculum, including the medial patellofemoral ligament with dynamic assessment if there is concern for patellar instability. Similarly, we can look at the vastus lateralis and the lateral retinaculum, though less commonly injured than the MPFL. The trochlear cartilage can be assessed if we are worried about an OCD lesion. And we can also look at the anterior horns of the medial and lateral meniscus if we're concerned about meniscal injuries. And finally, the distal IT band if we're concerned about IT band friction. So now we'll go over the images for the structures we just discussed under ultrasound. Obviously, in the upper right hand is the little icon for the scan transducer location. You have here the quadriceps tendon and long axis. The suprapatellar fat pad or the quadriceps fat pad is just deep to the quadriceps tendon. The prefemoral fat pad is superficial to the femur. And then you can see the bright white cortex of the bone as this hyperechoic line down here. The suprapatellar recess is here between the quadriceps fat pad and the prefemoral fat pad. And you can see that there's no evidence of an effusion in this patient, which provides some reassurance that there's not any intra-articular pathology that could be causing an effusion. So this is a transverse view of the suprapatellar recess. Once again, showing that there is no suprapatellar effusion. And in this axis, you can also see the quadriceps tendon in short axis. Next, we see the patella and note that there is no prepatellar bursitis, which again, we also did not see on clinical exam. One thing we do notice in this region right away is that there's these cortical irregularities. There we go, cortical irregularities and fragmentation at the inferior pole of the patella. And there's this anechoic area here that's really important to note. In the pediatric population, this dark anechoic, hypoechoic region is not actually fluid or an isotropy, but it's actually cartilage that has not yet ossified. So as we stated earlier, this patient is still skeletally immature, and the ossification centers or growth plates he still has those growth plates or ossification centers. And in males, this usually doesn't ossify until 15 or 16 years old, though sometimes can occur sooner, as young as 10 years old. So the main thing we see, again, in this view is fragmentation at this inferior pole of the patella, where there is that non-ossified cartilage. This is the transverse view of the area, where we see this cortical fragmentation along the inferior pole of the patella there. Next, we can look at the proximal patellar tendon and start to see hypoechoic thickening of the proximal patellar tendon and the non-ossified cartilage. The key finding is that we see involvement of both the cartilage and the patellar tendon, which suggests that the cartilage is actually getting pulled off by the tendon. The non-ossified cartilage, again, is something that we don't see in adults because in adults it has ossified down into bone. But in the skeletally immature, this hasn't happened yet, which is why you can get irritation of this tendon, but also the cartilage, resulting in this area in Sinding-Larsen-Johansson syndrome. Ultrasound examination also allows us to see that the most superficial fibers of the patellar tendon look okay. So the pathology is really only affecting the undersurface of the tendon or the more posterior fibers. Here is a video of the proximal patellar tendon going from medial to lateral. And you can see that it's in this center portion where you start seeing these changes right here. But on the more medial and lateral side of the patellar tendon, that looks normal. Oh, looks a little bit more normal on these images. And then there you see those changes. This is now a transverse view of that area. And this is a video going from distal to proximal in the transverse view. And at the inferior pole, or when we get more proximal, is where we start seeing those changes in the patellar tendon. You can also put on color Doppler here and note that we do not see any vascularity or hyperemia. And now we can also do a contralateral comparison. In this case, the comparison is not a perfect control because this kid also had some changes and some symptoms on the right side. But we can see that these changes aren't as significant as on the left. We can still see the non-ossified cartilage and a small cortical irregularity or fragmentation on the right, but we're not seeing that thickened or hypoechoic patellar tendon as we saw on the left side. So to complete the scan, we can now look at Hoffa's fat pad. And typically what you're looking for in this area is to see whether there is any edema within the fat pad. And lastly, we can take a look at the distal patellar tendon as it inserts onto the tibial tuberosity. And we do not see any tendon abnormalities or cortical irregularities in this area. One thing that we did see was that the patient did have a little bit of fluid in this deep infrapatellar bursa, but when we palpated with the transducer, he had no sonopalpation tenderness in that area. So this is the report that we documented, both with the normal and abnormal findings. Most notable are the abnormal findings, which are here in the patella. Along the inferior pole of the patella, there was hypoechoic thickening of the non-ossified cartilage with cortical fragmentation. There was no hyperemia seen on collar Doppler at this region, and so no palpation tenderness was present. And then at the patellar tendon, the proximal patellar tendon was hyperechoic and thickened. No hyperemia was seen on color Doppler at this region, and so no palpation tenderness was present. But the mid and distal patellar tendon did not demonstrate abnormalities. Otherwise, for the other normal findings, the quadriceps tendons, suprapatellar recess of the knee joint, Prepatellar bursa, Hoffa's fat pad, superficial and infrapatellar bursa were grossly normal, though we did note some trace anechoic bursal distension in the deep infrapatellar bursa. There was no sonopalpation tenderness in this region. So our conclusion is that here, let's see, oops. Here is that there was hypoechoic thickening of the proximal patellar tendon and non-ossified cartilage along the inferior pole of the patella with cortical fragmentation, and sonopalpation tenderness was present at this region. That confirmed our clinical suspicion. So based on clinical presentation and our ultrasound findings, he was diagnosed with Sinding-Larsen-Johansson syndrome. We ordered physical therapy, recommended ice and Voltaren gel as needed. He was encouraged to cross-train with other physical activities and sports, and he was able to return to competitive tennis after 1 month. Here are some key takeaways and highlights from this talk to be aware of. And it's the main takeaway would be to be aware of the pediatric versus adult patellar tendon conditions, as well as ultrasound findings. Again, the key is that in the pediatric patient, you have non-ossified cartilage, which may be more prone to having abnormalities and where you can have changes to the area that may not be present in adults. Ultrasound can be beneficial in these cases and should be used as a first-line advanced imaging modality in addition to x-rays for looking at pediatric patellar tendon pain. And finally, we may see a lot of changes in the patellar tendon or anterior knee on ultrasound in these athletes, especially who participate in jumping sports. And the key is to correlate symptoms with ultrasound findings to determine when and where they actually have pain. Patients with Sinding-Larsen-Johansson syndrome may have osteochondral changes in the anterior knee long-term, but may not actually have symptoms as adults. So we wouldn't want to make a big deal out of the cortical changes at the patellar tendon if this patient did not actually have pain. And in fact, some of these findings or changes may actually be adaptive to their sport. But based on our ultrasound exam and the fact that he was symptomatic, we did diagnose him with this condition. So I would like to take a moment to thank Dr. Shah for organizing and directing these educational ultrasound series, as well as for mentoring me through this case and throughout my time here at Vanderbilt. I'd also encourage any other fellows interested in participating to consider doing so and taking advantage of this great opportunity that he has set up for us. And I'll turn it back to Dr. Shah for further comments and open it up for further discussion.
All right. Thank you so much, Thea, for going through that case in such great detail. So yeah, I thought this was a great case to go ahead and bring up since it involved a pediatric patient in case, as we may not, always see this just because a lot of the providers see more of the adult population. But as you had mentioned, I think one thing to kind of really highlight for this case, if you don't see a lot of pediatric patients, is just being aware of those secondary ossification centers within the knee, especially where we're seeing along the patellar tendon, which can be occurring at that inferior pole, as well as at the tibial tuberosity, potentially with Osgood-Schlatter's syndrome as well too. So once again, as you kind of highlighted in some of those findings, at those areas for the non-ossified cartilage, is that it is going to appear, hypoechoic, which typically we're seeing with that hyaline cartilage. And that's something that can be then obviously a normal finding as those patients are becoming more skeletally mature. And usually that's going to be in the kind of later teenage years. So once again, kind of just awareness of pediatric findings versus adults, and then those conditions that we can see. Another thing to kind of highlight, as you had mentioned, I think it's always for any type of knee condition, important to kind of include that suprapatellar recess view, just to go ahead and look for any type of effusion. I think that's a very kind of quick screen that, sometimes on clinical exam, you may be kind of questioning whether they have any fluid. And I think it's so easy to just go ahead and put the ultrasound on to go ahead and look at that area to kind of actually confirm whether they do have an intra-articular effusion or not. And then that way, obviously, it can start to kind of clue you in more if you are concerned about an intra-articular structure, which may push you on to get additional, more advanced imaging, such as an MRI. And then lastly, just kind of something to know, in this case, we did use, color Doppler. We did not see any hyperemia or vascularity, which I think, sometimes can be, variable in these apophysitis cases, but I still think, important to go ahead and take a look at. And obviously, you had mentioned as well too, dynamic imaging, if you are concerned, about any type of, tendon tearing as well too, just because a lot of the time that can, make those, tendon tears a little bit more apparent on examination, and just also making sure that that extensor, mechanism, is intact. So those are just kind of the few of the points to kind of highlight, from the talk. So thanks again, for going through that, Thea, but also kind of open it up to, any questions, or discussion points, anyone else may have.
Yeah, nice job. Great start for the fellow series. Um, I'm gonna just probably reiterate some of your points, Stephen, but I have a pretty low threshold for radiographs in the knee. And Thea, I think your comments about is ultrasound appropriate is a good one. Certainly in this case it was. If I detected even a small amount of fluid on my ultrasound exam, I'm going to default to a radiograph. And in fact, when you put up your list of the differential diagnosis, radiograph becomes even more important. So in the knee joint, I have a really low threshold for obtaining radiographs, even if the diagnosis is fairly obvious. My protocol, since we're talking about protocols in this series, is fairly similar. If I'm doing an anterior knee protocol, I do include the retinaculum, the medial patellofemoral ligament, distal retinaculum of the medial side. And I also do include the articular cartilage. Pretty routinely, I include that. And, as I've mentioned before, all my protocols pretty much start with the joint. And so if I'm doing a lateral or medial knee protocol or even a posterior, I'm always starting with those anterior images, kind of highlighting what Stephen just said about looking for fluid in the knee joint, because that's going to make me think differently about the differential diagnosis. When I am looking for fluid, you did show that you flexed the knee, and I just want to highlight that if you don't see fluid with this slight flexion, then I go ahead and actually flex the knee a little further, and sometimes I'm able to push fluid up, into the suprapatellar recess. And I also assess this recess fairly carefully on short axis, as well as look at both the medial and lateral patellofemoral gutters, because oftentimes you only see a slight amount of fluid within the suprapatellar recess, but you'll see a little more fluid in the patellofemoral gutters. So those are the areas that I look for fluid. And again, if I do see fluid, I have a low threshold for radiographs. I think, Stephen, you highlighted this not only now, but in your presentation with pediatrics. When you're dealing with immature bone, contralateral views are very important, as you demonstrated, Thea, as well as Doppler imaging. And then we're getting into the weeds with Doppler imaging with skeleton mature, because the pattern of Doppler imaging is very important. So in this case, if there was Doppler imaging involving the hypoechoic thickening of the tendon itself, that's likely pathologic, versus if you see a small amount of vascularity within, let's say, the apophysis itself, that may be normal vascularity. And so there's some subtle differences to look for. And again, contralateral views can help you with that. I also see frequently a small amount of fluid in the distal infrapatellar bursa. And the difference is that it's usually a very small, fairly sharply demarcated triangular structure. And it's common to have fluid in the deep infrapatellar bursa. When it's pathologic, I usually see that shape change. So there's more fluid in it and it's more rounded versus in your case, when you had that sharp, small triangle, then that's usually normal physiologic fluid within the deep infrapatellar bursa. Now there's a superficial infrapatellar bursa, and that is always pathologic if you see fluid in there. And usually the superficial infrapatellar bursopathies are associated with some type of abnormalities of the distal enthesis of the patellar tendon. I've rarely ever seen this in isolation, maybe just once or twice from direct trauma, but it's usually associated with, again, a distal pathology of the enthesis. So again, great start and really good case presentation.
All right. Yeah, thank you so much, Doug, for those additional comments. I'll just go ahead and keep it open, though, just here for a minute, just to see if anyone else has any comments to go ahead and make. I think another thing to kind of highlight, just while we're kind of waiting for any additional questions, is Thea, as you had mentioned, sometimes these changes can be, more long term. And so if you're seeing a patient that now is a little bit, older, getting into their, 20s, it is possible that they're going to still have, long-term changes, related to both of these conditions. But obviously, one difference that you're going to see in the older population is that that tendon is going to go ahead and fill in where that non-ossified cartilage, was, but they can still continue to have some of those cortical irregularities. But that's where I think it, especially for the anterior knee and patellar tendon pain, it is so helpful to be using the ultrasound to actually, kind of correlate with the sonopalpation if they're actually having symptoms at that area, or was this a previous condition that they may have had, or are these just adaptive changes, kind of with their sport. All right. Well, unless there is any other discussion or questions or anything like that, we'll go ahead and close this out. So, thanks again for starting out with a great presentation, Thea.
All right. Thank you. Thank you, Dr. Schaff. Thank you, everyone. Have a great day.